Again, welcome. Good morning to everybody that's on. Welcome to the Residential Redesign Designation Application Instruction webinar for the new revised application. We welcome you to this webinar, and we're really happy that we're able to present this webinar. We've been listening to feedback from our providers who have completed some of the previous application, and we have done some simple revisions and formatting changes, and we will be going through those changes on today. After this presentation today, you will be able to locate the slides from this PowerPoint, this presentation is also being recorded. You will be able to go to the mctac.org website, and you will be able to listen to the recording as well as find the PowerPoint slides. That should be taking place in about 1 to 2 days, so please go and check on that. There's a lot to cover today, and so we will be here in conversation for the duration of this presentation, so there will not be any questions today. However, you can send any questions that you may have to the Pickham mailbox, which is pickham@oasis.ny.gov. So that's PICM@oasas.ny.gov. Today, we're privileged to have with us Mike Burke from the Program Review Unit, myself, Brenda Harris-Collins from the Pickham Division, Practice Innovations and Care Management Division, and also Henry Kurtzman from the Practice Innovations and Care Management Division. And we're happy to have you here with us today. Henry?
Good morning, everyone. These are really exciting times that offer our field tremendous opportunities to enhance staffing and services. So Part 820 regs were designed to integrate Part 819 intensive residential, Part 819.9 community residence, Part 819.10 supportive living, and Part 816.9 medically monitored crisis services. The residential redesign paradigm was designed to allow providers flexibility, and the regulations you'll find are much less prescriptive. Our focus is on good clinical practice and services that are participant-centered, trauma-informed, strength-based, and recovery-oriented. The application exercise was designed to elicit your clinical vision on how services will be provided. It should not be written by grant writers, but should include information from a transdisciplinary team. Many providers have developed change teams within their organizations that are working through this process of transformation and transition. What are you doing? How are you doing it? And who will be providing the service within your agency? Brenda?
Yes, so one of the things that OASIS hopes is to provide a success-oriented application process, and we've developed several tools to support the providers as they consider which elements best meet the needs of current and future service recipients. So we know that there are 3 elements for which a provider can apply for, which are stabilization, rehabilitation, and reintegration. You may apply for any or all of the elements. So you can apply just for stabilization, you can apply for stabilization and rehabilitation, you can apply just for reintegration, or you can apply for all 3. So whichever elements of care that you have decided upon, you can apply for those. Prior to submitting a Part 820 Pro application, providers are encouraged to utilize some of the tools that are available to you. There is a Part 820 Readiness Assessment document, and this was designed to support the successful transition to Part 820. In conjunction with the Clinical Advisory Group, there was an assessment tool that was developed, and there are some other tools that are available that may be helpful to you. We're asking, however, that you do not submit the residential redesign readiness document as a part of the formal application, but you may find it useful as they consider which of the elements to include in the formal application. You will find in the PowerPoint a link to where you can click on the OASIS website. You can go to the OASIS website and find these documents and tools available to you. Also, we are still in the process of ongoing learning communities and collaboratives that are being offered to facilitate a program dialogue for information. And you can either go to mctac.info@nyu.edu, or you can go to CASA-info@centeronaddiction.org. Okay, so I'll say that again, CASA-info@centeronaddiction.org. And you can go there and they can give you some of the information. We are actually in the planning stages of a learning collaborative that will begin to take place in New York City shortly. Also, one of the other reminders as you begin this process, or for those who have already began to have these change teams and look at the application, please begin to start talking to your field office coordinators. They should be engaged in the development of budgeting and exploration of startup funds surrounding implementation of Part 820 programming. This is important that this discussion begins right away, at the same time that this is happening, at the same time that you are working on your application. Lastly, the complete Part 820 designation application is located on the OASIS website as well. So there's a link in the PowerPoint, but you can also go to the OASIS website, you click on services, you click on certification, and then the first thing that you will find there is the residential redesign application, the new application. This webinar will explore the strategies required to complete a successful designation application, but be reminded that it will not speak to Medicaid managed care contracting. This is just speaking to the designation application. Henry?
Okay, so the next couple of the application form includes the following slides. It's going to talk about, the following slides will walk you through the actual application and explore the intent of the questions, which should be answered sequentially. So write the question down and then answer below it. There are 4 sections to the application which will be explored: application information, project narrative, staffing, attestation, and the attestation.
Okay. Section 1 is going to deal with identification of the applicant. In the first part of the application, you will find that we're asking for the entity administrative headquarters mailing address. We're asking you to put the applicant's legal name, enter the full site address, and also it's asking for an application contact person. We're asking that you would identify a contact person within your agency that is available to clarify any questions from the OASIS reviewers surrounding your application. This is a iterative process, and so once an application has been submitted, the reviewers review it. We then get back to you with any clarifications that may be needed, and we have a really open and rich dialogue on the application so that it is success-oriented. So we need someone that we will be able to contact, that we can have those kind of conversations with. The next part of the application is titled Conversion Site. We're asking you to enter the information exactly as it appears on your operating certificate for the program you are requesting to be designated. We're asking you to enter the full site address again. On the operating certificate, your specific designation will be noted once the application has been approved. The application is connected to the specific PRU. Therefore, if you have multiple PRUs, you will submit an application for each PRU indicating which elements of care you're applying for, as well as the specific staffing pattern within each PRU. We're asking you also to indicate the number of beds certified to this facility, indicate the number of beds proposed for the facility transition to Part 820. We realize that providers are really taking an overall look at their PRUs and their programs. So that means that this may be the same number of beds that you're presently certified for, or you may choose to decrease to accommodate your new staffing pattern. And there are actually some providers who are increasing to meet the vision of the transformation to Part 820. Henry?
Enrollment in a New York State Medicaid program. If a program is applying for Part 820 designation for either the stabilization or rehabilitation element, in addition to OASIS certification, the program will also need a New York State Medicaid number, an MMIS. The OASIS Part 820 designation application has been updated to ask programs to provide OASIS with this 8-digit New York State Medicaid ID number, sometimes referred to as an MMIS number. Most programs applying for Part 820 designation are part of a larger program or entity that is already enrolled in the New York State Medicaid program, and they should include the program's MMIS number in their OASIS Part 820 application. Programs can speak with whomever in their organization who handles billing to obtain this MMIS number. If a program is applying for stabilization and or rehabilitation elements and it does not already have a New York State Medicaid ID number, then the program needs to first check the box on the OASIS Part 820 application indicating to OASIS that the program will be enrolling in New York State Medicaid. By checking this box, the program will then receive an OASIS Part 820 letter of intent. You will need that letter of intent when the program completes the separate New York State Medicaid enrollment application. It must include the OASIS Part 820 letter of intent with the other materials included in the Medicaid program enrollment submission packet. The New York State Part 820 Medicaid enrollment application may be found at the Provider Enrollment tab located at the New York State eMedNI website. It is important to remember that providers do not submit the Medicaid application to OASIS. Instead, please ensure that the Medicaid enrollment package is sent to the address included in the Medicaid enrollment instructions.
And let me just emphasize that this is just for stabilization and rehabilitation.
Right. Yep. So here's the really fun part of this application. This is where you're exploring your vision, your goals, your mission. Right? Answer the questions in sequence. Again, clearly delineate which question you are addressing in your narrative by numbering them appropriately and being as succinct in your response as possible. The exercise is designed to elicit your clinical vision. In your agency, what will the element that you're applying for look like? In Henry House, stabilization will be housed with rehabilitation. We believe that participants heal in community and will utilize the participants in rehabilitation to model and support those in stabilization. Brenda's agency has a different vision of stabilization. It's a discrete dorm for stabilization, and Burke House has a completely different vision of how it will address those specific demographic needs of their population. So this gives you an opportunity to actually step back, look at all the processes that you have in place and what would you envision this new model of care to look like. So we're starting with the proposal narrative now. You'll find that the application information on the first section where they asked you for the conversion site is in a PDF format. Thereafter, we are requesting that applicants please identify the question that they're responding to, label them accordingly, utilizing a Word document format. So this Word document format will allow reviewers to ask for clarification and track changes, and it really simplifies this interactive conversation that we're attempting to have with you surrounding your application and your vision of transformation. Reviewers will be able to expedite the review process as opposed to having to search for your response within the body of the narrative. So program approach and services. All right? The first one asks you to identify how you'll target the element of care to specific patient needs. You're labeling that, you're writing that particular question down in a Word format, and then you're labeling it response PA number 1. Providers should identify the target population, the demographics, and the community needs that will guide the services within the proposed element of care. Number 2 asks you to provide a detailed list of expected goals with indicators of goal attainment and discharge or transition criteria. How will you know that the individual is ready to transition to another element of care or leave treatment altogether? Programs are asked to develop predicted element markers, including goals for completion of stabilization, rehabilitation, and reintegration. Identify for each element of care specific milestones to define when discharge or transition criteria has been met. For example, stabilization is complete when there's an elimination of withdrawal symptoms, decreased cravings, decreased mental health symptoms. For rehabilitation, that criteria will obviously change. Rehabilitation is complete when relapse prevention plans are in place. Self-regulation and coping skills are evident. Job readiness workshops or other employment goals are completed. Number 3, discharge planning must begin at admission and address the wide range of concerns. Participants should be linked to services within their communities to support long-term recovery. Discharge planning is really a key component and should be addressed in each element of care. So unlike how we operated in the past, when people first came into treatment, they had to wait until they had a certain amount of time in treatment before we would begin to address housing and employment. In Part 820, all of these services are front-loaded. Number 4 asks the provider to have the capacity to interface with Medicaid managed care companies. The agency should have a strategy as to how and who will be assigned to communicate with managed care companies. Some agencies may have all staff trained to provide this service, and others will assign key point persons to communicate with the managed care companies. Number 5 asks you to describe your experience delivering treatment services that utilize best and promising practices that are appropriate to each of the elements that you're applying for. So this may sound a bit confusing. We're asking for you to describe your experience and many of you say, well, we have no experience in doing stabilization. What we're really asking providers to speak to is best and promising practices that they're presently utilizing in the provision of treatment services. Our agency is trauma-informed as evidenced by the following. Our agency is strength-based because the processes are the following. They should further elaborate on how they will apply measurement-based care assessments tools to measure withdrawal symptoms and stabilization, evidence-based groups for rehabilitation, seeking safety, contingency management for something like reintegration. So we're asking you, if you look at the next required component, to describe your experience with the integration of SUD services with mental health, physical health, and other chronic health issues, pain management, or co-occurring disorders. How has your agency coordinated or linked individuals to mental health services, physical health services, vocational and housing services? How have they coordinated recovery-oriented services within your agency or within the community that you provide services in? The provider should demonstrate through documented staff training and case review systems the ability to address co-occurring mental health and substance use disorders, as well as demonstrate the integration of physical health with behavioral health concerns. So you're describing the process utilized within your agency to address co-occurring disorders, physical health concerns, through one, case conferencing with a transdisciplinary team. Speak to the ongoing staff training process that exists within your agency to enhance staff competencies in integrated care. Residential redesign is going to provide for staffing patterns that include healthcare professionals, doctors, psychiatrists, psychiatric nurse practitioners, RNs, and LPNs. Existing staff should be trained to interface in a transdisciplinary team approach, recognizing and breaking down silos to achieve better outcomes. Number 8 speaks to providers should show the ability to provide meaningful care coordination within its own staff or work with health homes. So speak to how your agency will coordinate care with other entities. 9 talks to clinical supervision, and clinical supervision is really the cornerstone of quality treatment services and ensures fidelity to evidence-based and promising practices, as well as provides the support that's going to be necessary for the paradigm shift occurring within residential redesign. Regular supervision, clinical supervision that is, has shown to improve outcomes for both staff retention and participant engagement. So what we're looking for you to do in this component is describe how often and in what format clinical supervision will be provided. Number 10 asks you to describe employment and educational services to be provided in each of the elements of care that you're applying for. Early engagement surrounding employment, vocational training has shown to retain the individuals in the treatment process. Employment and as well as housing services are, again, as stated earlier, front-loaded in this Part 820 transition process. Number 11 speaks to the provider demonstrating a clear understanding of trauma-informed, person-centered, recovery-oriented systems of care. Providers should describe the process and services that are trauma-informed. We know that you understand what those particular terms mean. We want you to clarify how they'll be implemented within each element of care. Another component of this question speaks to obtaining regular feedback from participants. How will you create a feedback loop within your agency between the participants in care and you and the staff? The third part of the question asks, how will you integrate recovery coaches or certified recovery peer advocates in the treatment milieu? So those are the required components.
Yes, thank you, Henry. So Henry just reviewed again the program approach and services required approach for each element, and that was attachment 1. We're now moving to attachment 2, which are the key concepts. And we want the applicant to demonstrate the ability to integrate these key concepts into your residential redesign vision. Number 1 deals with the shift from program-driven to participant-driven assessment, treatment planning, and service delivery. And so this is really a key concept that is one of the foundations and underpinnings of residential redesign. We're moving from program-driven to participant-driven. This really requires a paradigm shift in thinking from linear movement and phases of treatment to more individualized movement based on the achievement of the individual's milestones. So we know, for example, that some will move from stabilization to outpatient services and home-based recovery supports. Others may require rehabilitation and reintegration services. So it depends upon the individual, and it's really looking at what the individual needs and how that will determine their treatment plan. That also the assessments have to be really geared towards looking at the individual and developing those element markers that Henry spoke to, and actually service delivery. So this is a key underpinning that really has to be looked at, and we're looking for that in this key concepts as you begin to write that up. The second thing is treatment planning and decision making is based on an assessment of individual risk, resources, values, and preferences. And we want you to identify the assessment tools that will be utilized in your measurement-based care model for each element. So one of the things that we really talk to providers when we've reviewed their applications is really identifying how do you identify preferences and what the person, because that's what's going to drive their treatment plan. That's what's going to, looking at their risk, resources, and their values, and especially their preferences, that will drive the work that is going to take place. And so one of the things when you answer this, we're looking at how you will capture their individual preferences. What tool will be utilized to identify risk, resources, values, and preferences? We want you to speak to specific measurement-based tools that will be utilized for assessment of baselines to measure individual progress in the element of care. You need to have baseline assessments to demonstrate what the individual markers will be to move that resident from one element of care to another. For example, some mission assessments are the Locator 3.0, the MAST and DAST, Modified Mini, Post-Traumatic Stress Disorder Checklist. 5, the LIBET, the PHQ-9, the Fagerstrom Nicotine Dependence Scale, the Jung Anxiety Scale, the Clinical Opiate Withdrawal Scale, which is known as COWS, and the CWAS Scale, the Clinical Institute Withdrawal Assessment of Alcohol Scale. These are just a few of the assessments that you can utilize. There's also on the MCTAC website a listing of various assessments that you can also find there. And we've had providers that have begun to put it together a list. So there's a variety. You need to explore these based upon your population and your demographics and identify what assessments would be good for you. The third thing is that we want you to look at is service duration is based on individual milestones versus a program length of stay. So gone are the days of a 9 to 12-month program. You know, so now we're looking at a program, individual milestones that will move the person. Henry always says, you know, people ask the question, what is the difference between a 9-month program and a 12-month program? And the only difference is 3 months. But Medicaid managed care, we're preparing you for conversation with Medicaid managed care, and in that conversation, it has to be more than 3 months that determines the difference. So we're looking at how can you begin to work to a service duration based on individual milestones. We want you to demonstrate how the program will move individuals through care based on obtainment of the goals identified in an individual treatment plan, and speak to how your agency will integrate flexible lengths of stay. There is a shift in this concept, and you must be able to demonstrate your shift in thinking, especially around involving flexible lengths of stay, which are participant-driven. Question number 4, key concept 4, looks at medication-assisted treatment must be available and offered to all patients as indicated in each element, and staff must be thoroughly trained on uses of addiction medicine and its relationship to long-term recovery. Number 5 looks at the provider should demonstrate the ability to provide family-based services and address the impact of addiction on family systems, including family issues for those who are involved with the child welfare system. Providers should demonstrate the ability to provide family-based services or linkages to these services as needed. When we look at this and review this particular question, one of the things that we really try to get an understanding of is also who within your agency will be providing family counseling and what training does the staff possess. Because it's important that the staff has specific competencies to deal with this specific issue. So we're looking for those competencies when you answer that question around family, not only with family, but specifically also with this family issue. Number 6 deals with the proposal key concept is proposal must identify how the program will evaluate the sufficiency of medical, mental health, and clinical staff time. And we want you to indicate how adjustments in staffing patterns will be made. We want you to list the data sources that will be utilized to inform this decision. And this is a particular key concept that a lot of our providers have struggled with. And so we wanted to really talk to you today about, what is it that we mean when we talk about evaluating the sufficiency of your medical, mental health, and clinical staff time. What sources of information will inform your decision? Many agencies are using client satisfaction surveys to inform their decisions. If they find that they have a client satisfaction survey and the clients are saying they're not receiving certain things in a timely manner, that knows that maybe there's something that needs to be done to provide those services in a more timely manner. There's more staffing needed. They're looking at hospitalizations, outstanding incidents, looking at criminal justice center reports. You need to identify time frames to collect this information that will be in alignment with timely responses as opposed to annual surveys. So you need to do this more frequently and really look at that. At this time, we're going to turn it over to Mike Burke, and he's going to go over policies and procedures.
Good morning. I will be discussing the policy and procedure checklist, which is now attached to the application. This checklist is the tool utilized to determine compliance with the regulatory requirements found in Part 820. When you develop policies and procedures, it's important that you capture the day-to-day operation of your program. Remember, this final document will provide your staff with information as to how you conduct business. Therefore, when developing these policies, do not simply regurgitate the regulations. Make the policies your own. Please submit the policies with page numbers or policy numbers to facilitate a conversation if necessary. If you receive a summary of findings and items are noted as missing, please refrain from making changes to what has already been accepted. Limit the policies and procedures to those required in this checklist. The first policy has to do with admission criteria, and this is simply who do you serve, age, gender, specific targeted groups, and make a reference to the outcome of the initial determination in Locator 3.0. Each element has its own admission criteria, And reintegration has additional criteria which can be found in Part 820.12, B1 and 2. The initial determination can be found in Part 820.7, A1, which is comprised of 3 specific criteria that indicate the need for CD services. The initial determination should reflect all 3 of the specific criteria. The level of care determination would identify who completes the level of care, who signs off or documents its completion, and what protocol you will be using. The admission decision reference to this requirement can be found in Part 820.7, A4. And this policy needs to identify what staff is responsible for making the final admission decision and how this is going to be documented. Rules and regulations, confidentiality, and voluntary are referenced in Part 820.7, A4. You should develop a policy that describes the process by which residents are advised of the program rules, rights, a summary of the confidentiality requirements, and that admission is on a voluntary basis. Anti-discrimination policy. This can be found in Part 820.7A3 and denotes those instances whereby a person cannot be denied admission, and this applies to all 3 elements of care. The disease assessment found in Part 820.7C1 requires a communicable disease risk assessment to be conducted prior to admission. Transfer, which applies to all the elements, identifies the process utilized by the program which ensures a seamless transition from one element of care to another. This is also often called transition. The referral policy can be found in Part 820.7A4, and this policy includes a referral be made for those individuals that are not appropriate for admission into the program unless they are presently receiving services from another provider. Discharge criteria, which applies to all elements, can be found in Part 820.9B1 through 6. This policy stipulates the criteria that's found in this part. Involuntary discharge. This policy includes the process that must be taken when a resident is being discharged against their wishes. For guidance in developing this policy, please refer to Part 815.7, Patient Rights, and again, make sure that this policy applies to all elements. Discharge planning applies to all elements, found in Part 820.9, C1 through 3. Develop a policy that describes the development of a discharge plan with appropriate content and required signatures. You should consider, when developing the discharge plan, the final discharge plan, the time frames might be different based on Medicaid managed care requirements. Discharge summary applies to all elements found in Part 820.9C5, and this policy should denote when the summary is to be completed and the required elements. On to treatment recovery plans and service plans. You need to describe or provide a policy that describes who develops the plan, who reviews it, who signs it, and when. Policy should also contain expected plan elements. Completion time frames that are relevant to the shift to Medicaid managed care should be taken into consideration when developing this plan. Treatment plan elements are identified in Part 820.8. The treatment plan review policy will delineate the time frames and expectations for completion of a treatment plan review. Care coordination, referenced in Part 820.8B1, describes the requirements relative to a resident who's receiving services off-site, and this is required for all elements. On to staffing. The staffing policy will identify the various titles and respective qualifications appropriate to the element or elements requesting certification. Specific details regarding staffing are indicated in Part 820.6, as well as 820.10b for stabilization, 820.11b for rehabilitation, and 820.12e for reintegration. Moving on to screening and referral procedures for physical or psychiatric conditions. Medical assessment. Specifics with regard to timeframes for completion can be found in Part 820.7d2. The medical assessment will be utilized to determine the need for a physical examination. When developing this policy, please consider the abbreviated timeframes within the element in rehabilitation when developing this policy. Physical exam. Policy must include a procedure that identifies a physical exam will be conducted based on the results of the medical assessment for stabilization and rehabilitation. Time frames for completion must be included and consider the length of stay. Psychiatric assessment. A policy and procedure which stipulates that a psychiatric assessment will be conducted in the stabilization and rehabilitation elements. A schedule of fees for services rendered. If you have one, submit the fee schedule if one is available. If not, this requirement will be deferred and the policy will be reviewed at the first recertification review. Infection control procedures should be developed in consultation with medical staff and include universal precautions. Cooperative agreements. Provide a policy that includes a listing of those entities that you have or will have cooperative agreements with. HIV/AIDS education, testing, and counseling. This policy will focus on the provision of HIV/AIDS services, whether they are provided in-house or by referral. The use of medication-supported recovery policy should contain a statement of the program's provision of this service and its philosophy regarding this practice. Alcohol and drug screening. This policy and procedure will include the process and instances when a toxicology or breathalyzer will be conducted. For example, prior to admission, upon returning from extended leave from the facility, randomly, or when suspected use has occurred. Should include how results of testing are documented in the resident case record and be in compliance with Part 815.8 A and B. You should also include a chain of custody and should inform staff of the step-by-step collection process. Ordering, procuring, and disposing of medication as well as self-administration. This policy denotes who is responsible for ongoing monitoring and ordering of medications to ensure that residents have an ample supply. Once the medication is ordered, how is it obtained from the pharmacy? Do staff conduct a count upon receipt of controlled substances? Is medication properly disposed of? Describe the proper means of disposal according to DOH guidelines. Include the process for self-administration. Are residents observed when taking medication to reduce diversion? Are staff trained in how to properly document the self-administration of medication? Are you an institutional dispenser? If so, please include a copy of the certificate with your submission. Quality improvement. This policy must include identification of the Quality Improvement Committee members, the frequency of its deliberations, and its responsibilities. Should include findings of other management activities, for example, utilization reviews, incident reviews, reviews of staff training, development and supervision needs, surveys of resident satisfaction, and analysis of treatment data. Key performance measures. This policy will identify the clinically relevant key performance measures relative to the specific element of care. UR process. The utilization review process should include a procedure that ensures admissions are appropriate and discharge criteria are met. The utilization review plan shall consider each resident's need for continued treatment and utilize the locator 3.0. Emergencies. This policy and procedure provides staff with instruction on what specific steps to take in case of an emergency. Incident reporting and review in accordance with Part 836. The incident reporting and review policy and procedure must identify a staff responsible for administration of the incident management program. A reference to the annual review by the governing body, which is usually your board of directors, with regard to recording and reporting procedures, indicate how and what constitutes a reportable versus non-reportable incident and the steps staff must take to report to the Justice Center when appropriate. Indicate that the committee will monitor the overall effectiveness of the incident management program and the related procedures. In accordance with Part 836.5B5, the policy should identify the minimum standards for investigation of incidents observed, discovered, or alleged. The plan shall identify procedures for the implementation of corrective action plans when required. How does the plan ensure that corrective action is related from the committee or governing authority to the program representative responsible for its implementation? Committee composition. In accordance with Part 836.5F1, identify the members of the Incident Review Committee. Please be advised that the Executive Director may not serve as a member of the Incident Review Committee. Periodic training. Include a reference to the provision of incident report training and code of conduct, which is completed upon hire and annually thereafter. Retention of records. Include a time frame, minimum of 6 years, that identifies the length of time you will retain incident reports and summaries of the Incident Review Committee. Record keeping. In accordance with Part 820.8C2, this policy procedure shall include the frequency of progress notes entered into the resident case record. Additionally, all individual and medical contacts for the purpose of assessing, diagnosing, or treating the resident shall be documented in the resident record by the staff member delivering the service. The policy needs to include the agency expectation as to the time frame for completion of notes into the records. Educational services for school-aged children. This policy ensures that programs who provide services to school-aged children have the availability of required educational and child care services. Procurement, storage, preparation of food, and nutritional planning. This policy would describe who orders the food, how food is stored, how food is prepared, and who approves the menu with regard to nutritional planning. Records retention provides a time frame with regard to how long the resident case records will be maintained. Usually this is 6 years after the date of discharge or last contact.
Thanks, Mike. That was a pretty comprehensive exploration of policies and procedures. I think that a lot of what Mike was talking to you about had to do with taking a look at what the process is going to look like in this new Medicaid managed care world. So when we've received both the application and policies and procedures, a lot of energy has been spent surrounding the time frames. There is no Medicaid managed care company going to wait for 30 days or 45 days for a service to be completed. So we've got to filter through that new lens. Okay, I'm going to move on and talk to you about attachment 4, which kind of you'll be identifying the element that you're applying for, and we'll first review stabilization. Now, stabilization provides a safe environment in which a person may stabilize mild to moderate withdrawal symptoms, severe cravings, psychiatric and medical symptoms before referral or transition to another program or element of structured treatment or recovery. Stabilization requires the supervision of a physician and clinical monitoring. It addresses immediate needs for medical and psychological intervention. It provides the environment for education, induction, and monitoring for addiction medication where appropriate, and it allows time to assess other ongoing needs. Nutrition, wellness, vocational, housing. Okay, so the very first thing that you have to provide us with is a protocol for ancillary withdrawal services. In order to provide stabilization services, you must provide ancillary withdrawal services, right? And staffing for this element is going to be further explored, but will include medical personnel, mental health, clinical, and milieu staff that will provide intensive engagement services to reduce cravings and engage participants in a treatment process. So the providers should collaborate with a medical director to develop those ancillary withdrawal protocols that will be used to determine the level of severity of withdrawal. Include procedures for the clinical evaluation and the management of withdrawal syndromes and observation of individuals. This is not a research document or a narrative. It's a policy and a protocol developed with your medical director. Should you need further assistance in developing that particular protocol, we've got a contact person, which is Zoraida Diaz. She can be contacted at zoraidadiaz@oasis.ny.gov. Okay? After you've got that ancillary withdrawal protocol in place, we're asking for a description of services that will be offered. So each agency will be required to develop a vision of what this element of care will look like and the services to be provided. Detoxification from substances and alcohol, psychiatric evaluation, medical evaluation, vocational and housing evaluations can be listed in your services. Individual counseling, group counseling. So description should identify how often individual counseling will happen and what specific group counseling will evidence-based practices or groups you'll be conducting. The third is question asks you for a description of the assessment process, including time frames and staff that are responsible. So the description should identify the assessment process and what measurement-based care tools as well as time frames and staff responsible, then who are the staff that are responsible for triaging the participant. So some applicants did this in a very simple format. They created a table, and on that table, one column spoke to the assessments that they were conducting. The second column talked to staff that were responsible for conducting those assessments. And the third column talked to a time frame that this would be accomplished. Again, we're talking about viewing the time frames through a Medicaid care lens, so they would have to happen in that stabilization element very quickly. The fourth asks you for a sample treatment plan. An actual treatment plan should be developed for this element of care, and it should be measurable, attainable, time-limited, realistic, and specific. Identify what the services will be. Number 5 speaks to a metrics. A metrics for evaluation. How will your agency, evaluate its success or the success of individuals involved. So some examples of metrics are 80% of people in stabilization will have elimination of withdrawal symptoms, and you've got a way to measure that. It's measured by a decrease on the appropriate withdrawal scale, whether it's a COWS or a CEWA. Another example would be 85% will have a decrease in mental health symptoms, measured by a decrease in the DSM-5 cross-cutting symptom measure. 90% will decrease in trauma symptoms, measured by a PCL. So all of these assessments have objective measurement tools that are connected to them, and you can create your own metrics. Number 6 asks you to describe how intake services will be provided 7 days a week. So stabilization, as well as all the other services, are 7-day-a-week services. Once you're in the Medicaid managed care directory, right, you'll be getting referrals, all 7 days of the week. How describe your agency's ability to facilitate intakes 7 days a week. It obviously does not require intake services to be provided 24 hours a day. So I'll say that again, that although you will be conducting intake 7 days a week, you're not conducting them 24 hours a day unless your particular agency has the ability and staffing to make that happen. Rehabilitation, we'll quickly go through that, and Brenda will be able to do that for you. Go ahead, Brenda.
Rehabilitation, okay. So as we're looking for rehabilitation, the application is asking for a description of the services that will be offered. So one of the things that, and reviewing applications, we want you to really think in regards to what are the services for rehabilitation. They will not be the same necessarily as the services for stabilization. It is addressing different things. So rehabilitation provides a structured environment for persons whose potential for independent living is seriously limited due to significant functional impairment, including social, employment, cognitive, and ability to follow social norms that requires restructuring, social supports and behaviors in order to develop sufficient skills. These persons require a course of rehabilitative services in a structured environment with staffing to provide monitoring and support and case management. Rehabilitation is designed for individuals with significant functional impairment, social, employment, inability to follow social norms again, housing, continued clinical and medical services, individual, group, and family counseling should be provided as appropriate. Rehabilitative focus, improving life, vocational, daily living skills. There should be an increased use of program community to practically apply the learning skills. We should see identification and connection with outside community resources. There should be a development of pro-social communication skills, counseling that will address emotional regulation, and mental health symptom management. There's case management to link participants to housing and other community services. So let's be mindful, again, even in rehabilitation, we're front-loading some things. So typically there has been, in regards to housing, a person has to be there maybe 3 months before you begin to address housing. But this should begin right up front. The application should be started. So as you're beginning to look at how you're going to design your rehabilitation element of care, you're keeping in mind all of that. When you talk about the description of services, you've already worked out what your target population is and what are the demographics. So those services should match the demographics and the target population that you're trying to reach. So for instance, there's programs that have a niche, and their niche is criminal justice. So we're looking to see, based upon that the services that you're rendering and some of the specialized groups may be around criminal justice. We're looking at, do you have a lot of individuals who are trauma survivors? What type of services are you offering for them? LGBTQ, what kind of services are you offering for them? So a description of the services that will be offered. The second thing is a description of the assessment process, again, including time frames and staff responsible. This description should identify assessment process, again, and measurement-based tools, as well as time frames and staff responsible. And we talked about the table, the same table that you use in stabilization can also be utilized in rehabilitation. The third thing is a sample treatment plan. Again, this should not look, you can't put same as above, same as stabilization. It should be different. A person who's coming into rehabilitation is in a very different place. So, and we know that we are identifying these individuals. The Locator 3.0 is helping us to identify that. There's certain risks and resources that have taken place. And so we want you to really look at what a person's treatment plan should look like in rehabilitation. So that sample treatment plan, including goals for completion of rehabilitation. The fourth thing is, and also one thing about the treatment plan, that you need to have the treatment plan measurable, because it has to be able to articulate to Medicaid management care companies. The fourth thing is metrics for evaluation of this element. So in this element, you're looking at different, again, metrics. So you're looking at a decrease or elimination of cravings as measured by decrease on brief craving scale. 75% of the individuals that come in, 80% of the individuals will have a decrease in depression symptoms measured by the PHQ-9, but you need to look and develop those based upon your program, your vision.
Reintegration. Okay, so if you're applying for the reintegration element, reintegration provides a community living experience in either congregate or scattered site settings with limited supervision and or case management. Persons appropriate for this services are transitioning to long-term recovery from substance use disorder and independent living in the community. Reintegration in a congregate care setting or scattered site setting will provide opportunities to actualize skills learned in the treatment community. Okay, linkages to community services and resources. So, you know, filtering through this lens of being strength-based, trauma-informed, recovery-oriented, you know, many of you have been doing reintegration-like services for many years, but we're saying, hey, revisit those linkages and see if you can't broaden them, enhance them to support the demographics of your populations. We're looking for services for those transitioning to long-term recovery and independent living. Key to this element are the logistics involved in providing the services for individuals as close to their communities of origins. So if you're doing reintegration for residents from Syracuse, they shouldn't be reintegrating in Queens, New York. Participants should be transitioning to stable housing and employment. Access to services within the agency and linkage to services provided in the community. The care manager is there to connect participants to housing and recovery supports in the community, and some of the services that you're teaching are reentry skills, actualized connection with identified community resources, person practice skills in the outside community while continuing to receive support via the program community. So again, you will need to provide a sample service plan in reintegration, including goals for the completion. And as previously discussed, you know, you develop metrics specific for that particular element. And those obviously look different than stabilization because now you're demonstrating your linkage to primary care physicians, health homes, and stable housing. Brenda?
And just let me, you know, add to that. One of the things I think that there's been some confusion in regards to reintegration is that you know, we're looking for just a real emphasis, again, on those linkages. So a person in reintegration, for example, will be going to our outpatient program.
Right.
And a person in reintegration will be receiving whatever services, such as primary care and vocational services on the outside, mental health services they will be connected to there. So just being really clear, you know, as we move forward. So attachment number 5, organizational capacity. We want you to describe how your agency will support the implementation of each of the proposed elements that you have chosen, and explain how each element fits into your agency mission. You should describe how the agency's vision and mission will support the element of care. How will your current organizational infrastructure support the implementation of each element of care? The next thing that we're asking in regards to your organizational capacity is to describe the organizational capacity to collaborate with other community stakeholders, treatment providers, service providers, and managed care plans. Identify the service providers with whom you have developed linkages with, and include MOUs to demonstrate the linkages for the provision of specialized services. One of the things that you can see with residential redesign is there's a huge emphasis on community and community linkages. So in residential redesign, that's one of the primary goals, is to have service matching. So you also have to have choice and provide that choice for individuals. So your linkages need to be able to meet the needs of the individuals that you have coming to you. When providers identify specific services that they cannot provide the participant, they should show linkages to those services within the community. So this is really important. The third thing is attach a job description of the qualifications and experience that will be required for each key staff position. Demonstrate how your staffing for the proposed services meets the element requirements. Attach an organizational chart specific to the PRU. So we want to make sure that that organizational chart is not to your entire organization, but to that specific PRU, and that the job description should reflect experience and responsibilities. Fourth, complete and attach residential redesign personnel qualification worksheet and a staffing pattern worksheet schedule for each element you are applying for. The personnel qualification worksheet and the staffing pattern worksheet schedule should be specific to each element. Identify at the top of the worksheet which element of care you are referencing, and your workforce should possess experience and skills that correlate to the services provided in the element.
Okay. So we gave you sample worksheets as well as instructions on how to fill out those worksheets. So although you're sharing staff, that's caused some confusion, you still have to delineate some kind of a plan of how you'll utilize the staff in each element of care. So we're going to talk about program effectiveness, explain how you will use data to determine program effectiveness and make improvements in program practices. In developing your application, you've been asked to identify metrics for evaluation in each element. So demonstrate the utilization of UR and QA data and information and its impact on the modification of program practices. Number 7 talks to facility compliance. Facility must comply with Part 814 general facility requirements, including all federal, state, and code requirements. If necessary, attach a program plan for bringing the facility into compliance. We're asking you to clarify how your existing physical plant will accommodate the 820 enhanced staffing pattern, right? So describe how you will house the enhanced staff. Clarify how the physical plant will accommodate the needs for individuals in stabilization. If you had bunk beds before, you're now going to have single beds in that particular element. Well, you know, how's the physical plant going to be able to accommodate that? So that kind of spoke to attachment 7, which was facility compliance. Okay. Section 3 talks to staffing. And providers should confer with their OASIS field office for assistance in development of budgets to meet staffing requirements in the elements that they're applying for. So we've kind of been telling you that this should be a concurrent process. As you are developing your application, you should be in conversation with your field office managers, describing your vision of what the transformation will look like so that you can receive support for it. So we're going to talk about staffing patterns for residential redesign, and those are specific to stabilization and rehabilitation. I'm going to say it again, that those are specific to stabilization and rehabilitation and do not apply to reintegration. You can read that slide yourself. Staffing can be shared between stabilization and rehabilitation elements if you're doing both of those, so keep that in mind. Now we're going to talk specifically applicable to stabilization. The staffing requirements are that you have a registered nurse, an LPN, a medical director, a psychiatrist, that you have LMSWs or LCSWs or LMHCs, CASACs, and so you'll hear this in sufficient numbers, right, and sufficient time. And we discussed earlier how you're going to analyze what sufficient time is. Because this is all new to all of us, there are no prescriptions. There are no client-to-staff ratios, and because each facility has a different demographic and each community has different needs, that's going to be specific to your needs, and you have to have a way to evaluate that. So what we do need to say is that all medical directors, whether they're full-time or part-time, should be have a Data 2000 waiver so that they can prescribe. Staffing requirements, again, we've gone over this numerous times. There's a registered nurse, there's an LPN, and medical coverage. I think this is the question that keeps on recurring. Does medical coverage have to be on site 24/7? It does not. It can be provided on call depending on the participant demographics and your program needs. Reintegration, applicable to reintegration. So you need to have clinical staff in sufficient numbers to provide care coordination, so that's kind of broad, and you have to have milieu staff in sufficient numbers to facilitate activities of daily living, right? The staffing requirements for scattered sites. So staffing remains consistent. This has been a recurring question and a huge concern, and we're really sensitive to that. We'd like to clarify that staffing patterns within 819s and 819.10s are not changing. They're not changing because you're not getting a per diem rate to support any kind of changes. So applicants for reintegration elements of care should speak to the underpinnings of being participant-centered, strength-based, trauma-informed, and recovery-oriented, and again, stressing those linkages to community resources should be reevaluated to reflect the populations served. So those are the instructions that we spoke about earlier regarding the personal qualification sheets.
Henry, can you just speak to, we had a recent question in regards to reintegration and the difference between congregate care and scatter site, and just, can you just speak to the fact that scatter site doesn't, reintegration doesn't mean that you have to have a separate housing?
No, actually, we have providers that, you know, are doing reintegration as one of the 3 elements within their 819, and then we've got providers that are doing reintegration in a congregate setting, which would have been a halfway house before. You know, the idea, though, is when you're doing reintegration, the services are not in-house, they're in the community. That's the key, that the linkages to primary care, mental health, and any specialty services are all done in the community, and that the person meets the criteria that you've developed that identifies that they're ready to be in that element of care. The next 2 slides that we already spoke about, one were instructions for the qualification sheet, the other was the actual worksheet. So if you're telling us on those worksheets the proposed as well as the existing staff. So fill in what you propose their experience will look like for the particular positions that you're speaking about. We'd also like a staffing pattern worksheet, and we gave you an example of what that might look like. Identify the specific element because we're connecting the coverage to an element of care.
And that should reflect the weekly coverage for that element of care.
Correct. That should reflect, you know, the doctor's hours, and these are projections. You know, we really, you know, are kind of visioning, because we don't have the experience to draw on yet, as to how many doctor's hours I'm going to need in stabilization and how many doctor's hours I'm going to need in rehabilitation, or how many psych hours I have, but kind of, you know, think that through a bit and come up with some kind of a pattern that seems to make sense to you. Okay, so we've got the attestation piece. What's that about, Brenda?
Okay, so with the attestation, at the end of the application, you will see provider authorization for submission. And we ask for authorized provider representative signature, title, and date. The application must be signed and dated where indicated by the CEO or executive director, or if there is no such officer, a person authorized to act on behalf of the individuals or entity filing the application. If you are submitting the application electronically, the name typed in the space provided will be accepted as the person authorized to act on behalf of the provider, and is attesting that all information provided in the form is accurate and true.
Wow. So applications should be submitted in electronic Word document. We spoke to that earlier, that the first part is a PDF, right? So we're looking for the application to be sent to the Bureau of Certification. You'll be completing the application. Section 1 is a PDF fillable form. Section 2, attachments 1 through 3, you're providing those documents in a Word electronic document. Again, I'd like to stress that this application process is designed to be success-oriented. We're looking forward to working collaboratively with you as providers to ensure that the people we serve receive the best treatment possible. You can forward questions regarding the transition for Part 819, 816 to Part 820, again, to our Pick-em mailbox. We welcome all of those questions. Look forward to seeing your applications in the near future. I know we gave you a lot of information in a short period of time. We appreciate your patience. And again, this is just to bring you up to speed as to what's been going on. We've got 50 applications already in play. 5 of them have been completed and certified. There's another 15 that are in a contingency. So this is moving right along.
And one of the things that I want to say is that we are hoping that we know that because there was so much information that you will be able to go again to the website, MCTAC website, in 1 or 2 days. Listen to the webinar again as you're going through your app. Use it as a tool to guide you along with the policies and procedures and all of the things. There was a lot of information shared here today. Please use that as a tool. Get the PowerPoint, go through the PowerPoint, form your teams, your change teams, and begin to work towards this. This is not, the application has to be perfect and submitted in a perfect format, but send that application in, and then we begin to work with you towards that success-oriented application. Again, we want to thank you for attending this webinar. We thank CASA for helping us in this process, and Mike Burke, we thank you for joining us in this, and we hope that you have gathered a lot of information that will help equip you to do a success-oriented application. Thank you.